Hey everyone, I'm Michael Rosa, and today I'm going to be presenting on section 8.3 from our textbook, which is Depressive Disorders, Bipolar Disorder, Suicide, and Self-Injury. So let's get started on the first section, which is Depressive Disorders. And the two that our textbook focuses on are Major Depressive Disorder and Persistent Depressive Disorder. So here are the criteria from the DSM-5, or the Diagnostic and Statistical Manual for Mental Disorders, 5th edition, on major depressive disorder. So that includes depressed most of the time, so every day for a few weeks up to a few months, dramatically reduced interest in activities that you would normally find interest in, such as playing games with the family, significant challenges in appetite and weight. So even if you don't want to gain or lose weight, you will be doing that anyway. Your body will be gaining or losing weight without going on a diet or exercising. Additionally, significant challenges in sleep. So you might feel more lethargic and not able to fall asleep even though you want to be asleep. You feel like you're tired, but you're not able to. Additionally, physical agitation or lethargy. Lethargy is feeling kind of sluggish, kind of sloth. Feeling listless or with much less energy, so similar to lethargy, but feeling like you could just sit on the couch watching Netflix all day. Feeling worthless or guilty for no reason, so like, why did God create me? I'm such a terrible person. Why does my significant other love me if you have one? Or why does my family love me? Problems in thinking, concentrating, or making decisions, so maybe if you were able to make this certain decision in a few minutes, now it takes you a few days even, depending on the severity. And thinking repetitively of death and suicide. So for example, what would happen if I died right now? How would my family feel if I wasn't here anymore? How would I commit suicide? That's a big one, things like that. And planning out a suicide is an extreme sign of this. So that's when you definitely need to get help, more help on the suicide front. So now let's look at persistent depressive disorder, which is different from major depressive disorder. Persistent depressive disorder has similar symptoms to the major strain of it, but it's also known as dysthymia, and you have similar criteria such as difficulty in concentration and decision making, feeling hopeless, poor self-esteem, reduced energy levels, sleep, and appetite, which are all very reminiscent of major depressive disorder, but the major difference between these two disorders is that persistent depressive disorder is reduced versions of these symptoms, but over at least a year in adolescents and at least 2 years in adults. So it's less for longer. Bipolar disorder. So this is the second main section of this topic, and this I want to cover mania and depressive lethargy, which are the two major aspects of bipolar disorder that you will hear when it's discussed in professional or even non-professional settings. Bipolar disorder is separated into mania and depressive state. What is mania? Mania is a state of near euphoric feelings and a lack of good judgment. So feeling happy, like you could start a million projects that you've been putting off for forever, and you can all start them right now, even though maybe starting that business wouldn't be a good idea to someone with proper judgment at that time. To you, it sounds great because you feel like you're the king of the world. Additionally, loss of less sleep. So the body may need more sleep for cell regeneration and other processes, but the manic brain might not sense that and feels like it needs less sleep because it's in this manic, hyper-energized state. Positive emotions linger for an abnormal amount of time. So feelings of motivation, energy, happiness all last far longer than, even though it sounds like a good thing, far longer than one would desire or expect. So for example, even if a family member died or you're in the midst of the pandemic and you're still feeling these rapidly increasing joyful emotions, then that could be a sign that you're in a manic state. So creativity versus logic. Some studies have shown that those who are more creative inclined have higher instances of bipolar disorder, but this isn't super concrete. Those that have more logical sided thinking also are able to have bipolar disorder, but a link between creativity and this disorder has been found. And lastly, Americans have a 2 times chance of having a bipolar diagnosis than any other people groups that have been studied. So I actually interviewed my oldest sister, Elizabeth, who has been diagnosed with bipolar disorder in 2019, early 2019, and this is one of the things that she told me. She said that I experienced drug-induced dysphoric mania in college after taking an SSRI for the first time after the campus doctor prescribed it to me. So the first reason I included this was because it's kind of showing a real world, more personal example, brings it more to home, especially for me, obviously, because it is in my home, but also it's kind of a cautionary tale of making sure that you go to someone who is professional. Unfortunately, the campus doctor was more a licensed gynecologist versus a psychiatrist or a psychologist. And of course, that's a great profession, but for treating mental illnesses, maybe not so much. And that caused my sister to experience a separate form of the manic state known as dysphoric mania. Dysphoric mania is more of an extreme, even more extreme version of mania that includes psychosis symptoms. All right, next we're going to talk about some more general information about the previously discussed disorders. So in depressive states, both of the depressive disorders I recently talked about previously and bipolar disorder, compared to the manic episode, the depressive episode, both of these states include changes in cognition and behavior. So for example, lethargy behavior, sitting around more than you usually would, not finding joy in activities, and cognition as well. So more thoughts of suicide and macabre thoughts surrounding death. MDD, major depressive disorder, has around 360 million people, or 350 million, cases worldwide, and bipolar disorder has around 60 million worldwide. Unfortunately, women have a 2 times chance of being diagnosed with either of these disorders, whereas men have more disorders that are outward, such as alcoholism. Depressive episodes usually self-terminate or end themselves. This means that although they might last for a variety of time periods, so up to a few days, weeks, or even months, they usually will end themselves in bipolar disorder without too much external help. Even though that can obviously be very beneficial, usually these episodes will cancel themselves out. Additionally, stress can lead to these depressive episodes, varieties of stressors. So for example, losing your job, having an argument with a close family member or loved one, or the pandemic, for example. I know lots of people that have had more depressive episodes because of the huge stressor that is COVID-19. And depression diagnoses, unfortunately, have been getting earlier and earlier. So in the past, maybe around 20s, 30s, 40s is when depression and bipolar disorder would be diagnosed. But now into the teens and younger years, more diagnoses have been given and shown, unfortunately. So now we're going to take a look at 2 different psychological perspectives and what they think about these disorders. And that is the biological approach and the socio-cognitive approach. The biological perspective focuses on genetics. So the hereditary quality of these disorders has been shown to be very high, actually. So families that have a history of both depressive disorders and bipolar disorders have a much higher chance of giving that to their children, and more family members, even outside of the immediate family, there's a higher chance of mental health issues. Twins that were tested to have one that was known to have major depressive disorder, up to 50% chance that the other twin would have it as well. Identical twins, that is. And for bipolar disorder, 7 in 10 twins would have the bipolar disorder that the other twin had. Various genetic factors contribute to disorders, so we can't locate one exact gene or allele that equals depressive disorder, major depressive disorder, that equals persistent depressive disorder. We can't do that. So it's a variety. I believe our textbook explained it as a mosaic of different genetic factors that all combine to make major depressive disorder or bipolar disorder or any other mental illness. What does a depressed brain look like? So the reward centers in the brain have been exhausted and no longer have the same capacity for stimulation. So that's why pleasure and activities isn't as high as it usually was. And norepinephrine and serotonin, which are both chemicals in the brain that deal with happiness and motivation, those are no longer being processed by the brain correctly or even produced enough by the brain. And so many drug treatments affect these chemicals. For example, SSRIs deal with serotonin. And a fun little tidbit that our textbook gives is that running can actually help produce serotonin, and so exercise is a great way to help with these disorders. And the nutritional effects on the brain and these disorders, diet is a huge one. Eliminating foods such as excess sugars can really help in these disorders. And a Mediterranean diet has various benefits. Our textbook claims on different aspects of major depressive disorder, persistent depressive disorder, and bipolar disorder. And alcoholism and excessive drinks of alcohol has been shown to be very strongly linked to depression. So that's a warning for when you come of age to drink, that over abuse of alcohol can definitely lead to more depressive states. All right. The sociocognitive perspective focuses less on genetics and more on the social and cognitive perspectives. Who would have guessed? So low self-esteem and extreme pessimism can definitely lead to depression and bipolar disorder. Styles of explaining situations is linked to this. So what this is a style or way that a person views things that occur to them in their life, daily life. So a person with a positive explanatory style would see an inconvenience, such as somebody maybe blocking or cutting them off in traffic or something that is small like that. Temporary, it's specific to that situation, it's external from you, it doesn't really have anything to do with you, and that leads to successful coping with the situation. You can live your day without constantly thinking about that person that cut you off. Someone with a negative explanatory style, which leads more into a depressive state, would be that event is very stable to that moment and all moments. It always happens. There's no way to get out of it. I'm trapped in that situation. It's global. It's not just here. It happens all the time. It's overwhelming. Whereas compared to the positive explanatory style, it's not overwhelming. It just happened once and it's specific to that situation. In addition, the person with a negative explanatory style would see it more as an internal issue, so focusing on the internal state, so I'm a terrible person, etc., and that leads to depression and other depressive symptoms. Additionally, gender and rumination. So women, again, have higher chances, as we've seen before, for developing depressive episodes, and rumination. So rumination is compulsive fretting and overthinking about something that might not actually seem so big, but they expand it a lot. And so I actually experienced this a lot, but rumination can cause spiraling. So something that seems small, focusing on it until it seems like the biggest issue in the world, and that can lead to a major depressive episode. So depression is very common and getting more and more common among young Westerners. And some of the theories of this are, of course, social media, as we've heard a million times. That doesn't make it less true. And also individualism has been shown to be linked to depression. And the last thing I want to mention, I kind of mentioned it a few seconds ago, but depression is not a single moment. It's of onset. It's more of a cycle, and it's cyclical, meaning that it's hard to get someone out of a depressive episode because they just keep going around and around in circles and talking themselves into the depressive state. So definitely be there for someone that you think might be experiencing this, because it's almost impossible to get out of a depressive episode with your own strength. So now I'm going to talk about suicide and self-injury. So obviously there's a little trigger warning if you are not a huge fan of those topics, or you might feel that you will get upset by them. Suicide risk factors, there are six different categories that our textbook mentions. The first is nationality. Out of Europe, America, Canada, and Australia, Europe was actually shown to have the highest amount of suicides, unfortunately, out of those different nations. Race, white Americans and American Indians in America have a higher rate of suicide compared to other nationalities in America. Gender or sex, women have more attempts on their lives, but men actually have more complete suicides. A quick note I want to say about that is it used to be successful suicide attempts, but nowadays it's a lot better to say complete, because successful sounds like it's a good thing. So that's just something to keep in mind when you're talking about this very touchy subject, which it should be. It's very important. Additionally, age. The age range from 45 to 64 years old actually shows increased signs of suicide and attempts of suicide, and then it kind of goes down, and then 85 and up, it increases a lot more, interestingly enough. Seasonal differences. Suicide is actually highest in April and May, and in the middle of the week. Most suicides, 25% of suicides, occur on Wednesdays. And lastly, suggestive content, so TV shows and movies that include a lot of dialogue or themes surrounding suicide have been shown to be linked to increased suicide attempts. All right. So here are some signs to watch out for if you think someone that you know might be experiencing suicidal thoughts or attempts. Most suicides do not occur when energy is low and the depression is stronger, but actually during a more of a recovery state in which the person now has enough energy and, unfortunately, motivation to carry out that suicide attempt. So if you know a person that was majorly depressed, had a major depressive disorder, and is starting to get better, make sure you persistently check on them. Verbal hints, so I want to kill myself, even though that's been increasingly a joke nowadays, which I think is horrible. Watch out for that, because that can be a secret plea for help. And other verbal hints, such as repeated talking about death. In fact, that's the last one, preoccupation with death. So like, what would you do if I died? How do you think the best way to die is? Things like that. And giving away possessions. So if you know someone had a strong connection to a certain object and they're giving it away, that's a telltale sign of don't think that their time on this earth is going to be so long. And withdrawal into themselves, that's pretty self-explanatory for a suicide. I actually, personal story, had a friend that showed a lot of these symptoms, and on the next slide, let me show you tips for helping someone who appears preoccupied with death or shows that signs of maybe thinking about suicide. I used all of these with that friend, and they got help and are now a lot better. So listening, don't try to solve the issue immediately. That generally doesn't help, but just listening to someone and making them know that you're there for them is a huge factor in helping them. And try to sympathize or even empathize with them. So sympathy is, I'm so sorry, but empathy is more of trying to put yourself in their shoes and experience what they're experiencing. That is extremely beneficial. It makes them feel like they're not so alone. Suggest a professional after you've listened. Don't try to do that immediately, obviously, but somebody who is licensed in treating this will be far better than anyone else in treating suicide. And contact your trusted adult. So in my experience, I contacted a trusted adult. That trusted adult contacted a trusted adult of the other child, and they got, after I listened to them, of course, and they got professional help, and they're a lot better now. So that's just a nice little success story for a pretty sad topic. Non-suicidal self-injury is pretty severe. It ranges from burning one's own skin, cutting one's own flesh, hitting one's own self, inserting objects under the nails or into the skin, and self-administering tattoos. So all of those, of course, are horrible and make you cringe. So why would a person do this? Well, one, some causes are bullying, harassment, various stressors, as well as depression and anxiety. All those can lead to self-harm. And pain can be seen as a distraction. I know definitely for cutting flesh, some patients will see that as kind of a release of the internal pain through a physical wound, which to you might sound strange, but to them in that depressive state, that is extremely normal to them, or not normal, but they see it as a helpful coping mechanism, which it isn't very helpful at all. Maybe for the moment, but not for long term at all. And will very much need professional help. Attention and distraction, or attention attraction, I apologize. So if a person isn't really willing to ask for help, then self-harm can be a silent plea for help. And the help from others is the desire that they are trying to attract. And then social pressures can also really lead to, especially if maybe if you're in a sort of a gang kind of situation in some neighborhoods, then maybe even self-administering a tattoo would be a common example there, maybe, and other various social pressures. So that's it. I'm Michael Rosso once again. Thank you for listening to this downer of a topic, unfortunately, but I think there is some hope in learning about it. And have a great rest of your day.